nationally in our fight against Alzheimer's disease. My role there is I oversee all of the research having to do with people. So I'm not the person in the lab with animals or with petri dishes. I'm the person who oversees the stuff going on with trying to figure out how to diagnose this disease, trying to treat it, and most importantly, how to prevent it. So that's where I'm coming from today. Let me start by just giving you a little story of something that happened recently. There were a couple folks in my waiting room, and one of them says to the other, "Hey, I just went to this great restaurant in the South End with my wife." The other one looks at him and says, he's one of those people in the waiting room who really doesn't want to talk to anyone. He's there, he's a little nervous. He says, "Oh, really? What was the name of the place?" The first one says, "I was afraid you were going to ask that. That's why I'm here to see Dr. Stern. I just can't remember things like that. But wait a second, what do you call that long-stemmed flower that people give on special occasions?" And the first one looks at him and says, "You mean a rose?" And the first one says, "Yeah, that's it." And he turned to his wife and he said, "Rose, what's the name of the place we went to the other day?" I'm glad I got a chuckle. And why am I starting off with a joke? Not just to kind of get people in a good frame of mind, but to also tell you how important it is to have a sense of humor. And so I really try to stress to anyone involved with this disease that it's not just important to have a sense of humor. It's okay to laugh. There are some really funny things that can happen with a person with Alzheimer's disease. It's a little strange, it's a little scary sometimes, but it's okay to laugh. And it's so important for everyone involved. The individual with Alzheimer's, the loved ones, the professionals, anyone working with the person. It's okay and very important to have a sense of humor. There's other things that begin with the letter H that are also needed when dealing with this disease. Very important things. And they all happen to start with the letter H. Can you think of any other words that would be needed to deal with this disease that begin with the Oh! How about that? I knew you were going to say that. And I didn't pay her to do that. What else do people need? Help. Isn't that amazing? I give this type of talk probably once every other week. And it always works out. Those are the critical things that people need. You have to have hope, or you don't wake up in the morning. You need some reason. And you can't go through this alone. This is a difficult journey. And so it's okay to reach out and get some. One of the best places to get help in this journey is the Alzheimer's Association. They have so much to offer. You can find them online, by telephone. Their main office is in Watertown, but they have stuff going on everywhere. There's other words that I keep hearing when I give talks like this that begin with H that I don't have on my slides. Things like you need humility. That's a real big one. But let's move on. I'm going to give you a test. That's why you came here. You're going to have a test, okay? The first test is this. This is a true or false question. When you look at this older Superman, wrinkles and all, about to jump out of the window, and he says, "Dang, now where was I going?" And it says on the bottom, Superman in his later years. So the test question is this. Is this a problem of normal aging? Is this just normal aging that Superman would forget things like that? Or is there something wrong? So true or false? Is it true that it's just part of normal aging? How many people think true? How many people think it's false, that there's something wrong with Superman? How many people are just afraid to raise their hands in public? Well, indeed it is false. It's a myth in our society that if you live long enough, you're just going to get Alzheimer's disease or dementia. The fact is, now we know that Alzheimer's disease and other causes of dementia are not part of normal aging. They're not an inevitable part of getting older. Almost everyone experiences some mild forgetfulness. everything gets a little creakier, slower as we get older. Our brains do too. But not everyone develops a brain disease, such as Alzheimer's disease, that results in significant problems in memory, judgment, personality, behavior. Millions and millions of people get to a very ripe old age, 50. No, they get to ages in their 80s, 90s, even hundreds, with intact memory and very little decline in their mental abilities. So, when there is a significant decline, it's not part of normal aging. What is it? There's a problem. What do we call that problem? What do we call it? It used to be called senility. And thank goodness we're not calling it senility anymore, being senile. Anyone have any idea what the Latin root for senile is? What it means? Senile just means old. That's all it means. And yet in our culture, in our society, we have taken that to reflect this problem with thinking and memory that is much more prevalent as we get older. But get that out of your head. Let's not use the word senile anymore because it's, I want to become senile. In other words, I want to become old. But the other word that we now use is dementia. But I can't tell you how often people are confused about the difference between dementia and Alzheimer's disease. And not just folks in audiences like this, but I train and teach neurologists, geriatricians, psychiatrists, primary care physicians, other neuroscientists, and people really don't know that very basic important thing. What's the difference between dementia and Alzheimer's disease? So I'm going to teach you. This is one of those things that if you can just walk away knowing this, you'll learn something important. So let's talk first about dementia. Dementia refers to the new loss of memory and at least one other area of cognitive functioning. Judgment, language, oops, my mic goes out. So you have that new loss of memory and other functions, but it has to be significant enough to get in the way of social or occupational functioning. In other words, it gets in the way of routine, independent living. So this is the entire definition of dementia. It's when you have significant memory and other cognitive change that's bad enough to get in the way of living the way you used to, being independent. That is all it is. Dementia is not an illness. Dementia is not a disease. It's kind of like having a fever. If you have a fever, what does it tell you? You're sick. Yeah, that's all it tells you. Something's wrong. If you have dementia, it tells us that something's wrong with the brain, but it doesn't tell us what it is. So, dementia is the end product of many different things. It's just a clinical syndrome. It's a bunch of symptoms like having memory problems, other thinking problems that are bad enough to get in the way of daily life, but it's not the underlying cause. There are lots of different causes of dementia. Some of these causes are reversible. By that I mean if you treat the underlying problem, the dementia will go away. Things like out-of-control hypothyroidism, certain vitamin deficiencies like B12 deficiency, even major depression. Clinical depression is a brain disorder that if it's untreated, it can lead to cognitive difficulties and memory problems that are bad enough to get in the way of life. In other words, dementia. But that's not why we're here. We're here to talk more about the progressive, or what we call neurodegenerative diseases, of which there are many that can lead to dementia. Things like vascular dementia, It used to be called multi-infarct dementia. That's where you have a lot of changes in your brain due to blood vessel problems, strokes, other changes with blood vessels. And if it gets bad enough, it can lead to dementia. There's other diseases like frontotemporal dementia, dementia with Lewy bodies, chronic traumatic encephalopathy, which is an area that I specialize in, which is what we hear about with former football players, people who hit their heads a bunch, then later on in life developed a degenerative brain disease. But that's not the big stuff. Those are relatively uncommon compared to Alzheimer's disease. And Alzheimer's disease accounts for around 3/4 of all cases of dementia. So, here's a take-home message. Dementia is a clinical syndrome, it's not a disease. Alzheimer's is a brain disease that eventually, when it gets bad enough, leads to dementia. So it's not like you have a little bit of dementia, and it gets bad enough, you have Alzheimer's disease. It doesn't work that way. It's kind of like being a little bit pregnant. You have Alzheimer's disease, and as you'll hear in a few minutes, that can start maybe 20 years before you ever have any symptoms. And then it starts destroying the brain, and it's only when it destroys enough brain tissue that the memory and cognitive difficulties become bad enough that you can't live independently or as well independently. That's when it would be called Alzheimer's disease, dementia. Questions? Does that make sense? Now you know more than your doctor. So why are we even here talking about it? Well, because it is an epidemic. It's truly an epidemic. Every 68 seconds, someone in the United States develops dementia from Alzheimer's disease. Just in our country alone, we have well over 5 million people with Alzheimer's dementia currently. And that's going to increase exponentially over the next few years. And so by 2025, it's expected to be over 7 million Americans with dementia from Alzheimer's, and by 2050, 14 million. Why is it growing like this? Two words, both begin with B. Baby boomers. Us baby boomers are turning age 60 at a rate of 330 an hour. And with that comes the increased risk of developing this disease. Now remember I said getting old doesn't mean you will get this disease, but it is a disease that is more commonly seen as we get older. I want you to think of this. We human beings are not meant to live past the age of 40. We're supposed to procreate, have children, help them grow big and strong and safe, maybe help them have their children, and then our bodies were meant to give up. But now, through what has been an incredible change in modern medicine, as well as industrialization, we're living to very ripe old ages. Because we're not dying of other things that would have hurt people earlier. And so we're seeing all kinds of illnesses and disorders and conditions and diseases as we get older. Think of it. Arthritis, heart disease, cancer, cataracts. All of these things that affect older people we wouldn't have ever seen before. Alzheimer's disease and these other neurodegenerative brain diseases are things that you wouldn't have seen earlier. But now we are living to the point where our brains are getting worse and worse with these diseases, so we then see the product of it, which eventually is dementia. So what about these numbers right now? What about this incredible tsunami that is now happening in our society because of this disease? 1 out of 9 people age 65 and older has dementia from Alzheimer's disease. 1 out of 9. Here's the scary part. 1 out of 3 people age 85 and older has the dementia from Alzheimer's. Some reports suggest it's even 1 out of 2. 1 out of 2 or 1 out of 3 people age 85 and older has this disease. Now that's the glass half empty. The glass half full is 1 out of 2 or 2 out of 3 people age 85 and older do not have it. So it isn't just an inevitable part of aging, it's a disease that is common. In fact, it's the 6th leading cause of death in our country. 6th leading cause of death. And it's the only cause of death amongst the top 10 causes of death in the US that can't be prevented, can't be cured, and right now can't even be slowed down. Here's some numbers from 2000 to 2008. These are mortality rates, death rates in our country. What it shows is that deaths from stroke, prostate cancer, breast cancer, heart disease, HIV/AIDS, all of these things went down. The death rates, the mortality rates went down during that 8-year period. But mortality rates from Alzheimer's disease went up 66%. So yes, indeed, it is a fatal disease. A lot of people aren't aware of that. Last year, there were probably well over 500,000 deaths reported due to Alzheimer's disease, but the numbers are probably much, much higher because it's not usually written on death certificates, so we don't really know. The average time between diagnosis and death is around 8 years. This is just an average. Some people can live 20 or more years after they're diagnosed. Some people it's much shorter. Why? Well, it depends on a bunch of important variables, such as how advanced was the disease when the person was diagnosed. It's not like, poof, you get the disease, you go to the doctor, there's a test, you've got it. A lot of people never go to the doctor. A lot of people never get diagnosed, but when they do, they can get diagnosed anywhere in the continuum of this disease process. Another issue is the age at diagnosis can play a big role in how long someone lives with it. Overall health status, things like this. And what is it that people die of from this disease? Usually, it's an infection, such as pneumonia. If the person can no longer get out of bed, can't walk, can't ambulate, has a hard time swallowing, then they can aspirate, get something down their windpipe, and then they can't cough well, and they're not moving around, and so it becomes infected. And then the person can't fight the infection. There's other infections like urinary tract infections too that are common. But sometimes the brain just gets so destroyed by the disease that it can no longer support life. And the person just passes. All right. Let's talk about not just the numbers, but the impact of this disease on the individual as well as on the caregiver. So here's my favorite way of describing the huge impact that having Alzheimer's dementia can have on both the person with it and the caregiver. Can't see the slide. It's these two dinosaurs left on an island with Noah's Ark sailing away, saying, "Oh crap, was that today?" But seriously, let's talk more about the impact on the individual. This is a self-portrait by an amazing portrait artist named William Utermullen. Look at that. I mean, that's an amazing self-portrait. He was an internationally known portrait artist. In fact, I found out that one day when I was giving a lecture like this in New York, in Manhattan, as a fundraiser. There were a lot of very wealthy, kind of snooty people in the audience. And I show this picture and someone screams, "Oh, William, he did my portrait in Paris." So I knew I caught that for their attention. But look at this, 1967, that was a self-portrait. Unfortunately, around 30 years later, he was diagnosed with Alzheimer's disease and the dementia from it. His memory was shot. He could not remember anything from moment to moment. But look at this. He still could do that. That's amazing. Imagine someone with Alzheimer's dementia being able to paint that. Unfortunately, the disease then started to rapidly progress. And so 1 year later, this is the best he could do. 1 year later, and he's not trying to represent how he feels. This is as good as he could possibly paint it. 1 year later, and it's 1 year later. Since passed, but I'm showing you this to let you know that this is not just a memory disorder. Look at what it did to this incredible artist's ability to do what he was so great at. This is a brain disease that affects the entire brain. But let's go over the symptoms of Alzheimer's. Yes, indeed, memory problems are the first problem. And that's because the part of the brain that's responsible for making new memories, it's called the hippocampus. It's deep inside the brain, kind of deep. That part of the brain is one of the first areas to be destroyed by this disease. And so if you don't have the structures of the brain that are responsible for getting new information in, for making new memories, then you can't do it well. And so the problem with this memory difficulty in Alzheimer's disease is the inability to learn and store new information. Okay? The inability to learn and store and recall the stuff that you just learned. It is not a problem with remembering things from the past, from the far past. In fact, that it's really, really hard to lose those memories. So, for example, the person with Alzheimer's dementia will be able to tell you all about the details from their wedding, from their time in the war, from third grade schoolmates. And they may start telling those stories over and over again. Which is a great example of what's going on. They don't remember that they told the story, because that just happened. But they remember the stuff from the past. A great way to think about this problem with new learning is to think about a file cabinet. It's tax time right now, right? So if you're anything like me, after your tax returns are all done, you might have a little bit of time to put them in the file cabinet. Sometimes, when I get the time, I will organize it. I'll put it in a manila folder and write 2014 taxes, and then I'll put it in a green folder that says taxes, and then I'll put it in the file cabinet that says finances, and then I can easily find it later on. Sometimes, however, I don't have the time, or I'm more disorganized, and I'll just be in a big pile, but then after a year, I'll just shove it in the file cabinet. And it's in a big pile with everything else, but at least it's safe and sound in the file cabinet. So later on, if I need to find that tax return, let's say I'm being audited, I know where it is. If I organized it, great, I can get it easily. If I threw it in a pile, it's going to take a little more time. I'm going to have to go through everything. But it's there. The person with Alzheimer's disease, using this analogy, that file cabinet does not have a back to it. So you put the information in, and it flies right out. Whether you put it in an organized way, or whether you put it in a haphazard way, no matter how hard you look for it, it's not there. That's why it makes no sense to say to someone with Alzheimer's dementia, remember, dear, we just talked about that yesterday. You know, dear, remember we went out with so-and-so? Or remember we talked about you're not supposed to drive? Or remember we just spoke on the phone 2 hours ago? No, I don't remember. person might say, oh, of course, and put up a good front. But the part of the brain that makes it so those things can be stored is gone. No matter how hard they try, no matter how many cues, can't be recalled. So that's the memory problem. But it's not just memory. It's also problems with things like planning and organization and solving problems and decision making. By definition, because it's dementia, there could be difficulty with completing familiar tasks at home or at work or at leisure, hobbies. There could be confusion with time and place, becoming disoriented. There could be trouble understanding visual images and spatial relationships. Think about in driving. If you are at an intersection with a light, one of the most difficult things to maneuver is taking a left. It requires incredible spatial understanding, the ability to judge how fast that car is coming toward you, how you need to turn to get into that right lane, judging how many people are coming from different directions. If you're spatially impaired because of this disease, you can't do that. But there's other things too. There's problems with coming up with the right word, or in speech or writing. Not just the typical tip of the tongue that we all get, but the problem that gets in the way of speaking, and you can't get your point across. I'm trying to just make an example. Where it gets in the way of being able to communicate. There could be problems misplacing things or losing the ability to retrace steps. Decreased or poor judgment. There could be problems with withdrawal from work or social activities. Not just because the person is afraid of doing things or doesn't feel like they can, but because there's an actual loss of drive. The part of the brain that's responsible for oomph. That's a scientific word, the oomph part of the brain. That's hurt. There's also real changes in mood and personality. But sometimes it's not just depression that you might see. It can be apathy, which is more of a brain disease symptom, where there's a loss of interest in things that used to be exciting. There's a loss of emotional connection with stuff. They might not be sad. They just might not care. And then one of the most difficult things is poor awareness and insight. Poor awareness and insight. This actually has a fancy neurological term that goes with it. It's called anosognosia. And what it means is, get this is the definition of it, is the neurologically caused inability to be aware that you have a neurologic problem. Let me say it again. The neurologically caused inability to be aware that you have a neurologic problem. What a concept. So it's not that you are hiding it or have it, you're being defensive or you just don't want to admit to things. It's the inability for the brain to be aware that it has a brain problem. And you combine that with a memory problem, the inability to learn something new, remember that you had a conversation about something. And that leads to this kind of discrepancy between the experience of the individual with the problem and the people around them, caregivers. Because often when you have this combination of loss of insight into having the problem and you don't remember that you were told you have the problem, or you don't remember that you had a difficulty doing something yesterday, you're fine. But the person trying to interact on a regular basis, that can be a pretty hard thing. Is there a kind of a general course that this takes? Is it that in every patient, first it starts with memory problems, and then it goes to language problems, and then it goes to this or that? Absolutely not. It's a very individualized type of disease. We say in the field, if you've seen one Alzheimer's patient, you've seen one Alzheimer's patient. All right, let's change gears and talk about the economy. That seems to always be on everyone's mind. Why am I talking about the economy with this disease? Well, quite frankly, honestly, without hyperbole, Alzheimer's disease is going to be one of the most important reasons for the bankruptcy of Medicare and the continued incredible problem in our economy. Why? Because the national cost for caring for people with Alzheimer's disease this past year was around $200 billion. $200 billion. Remember that stimulus bill? This is a quarter of that entire stimulus bill was for this one disease. And that's going to rise to over $1 trillion per year by 2050. Last year, Medicare and Medicaid paid $150 billion in healthcare, long-term care, and hospice care for people with Alzheimer's disease and other diseases leading to dementia. The average cost for memory care, assisted living, is around $60,000. Costs that much. These places aren't making a lot of money. But who can afford that kind of cost on a regular basis? The cost to businesses, small and large, for employees who are dementia caregivers is around $37 billion a year. Why? Because the caregivers have to take time off from work to take care of their loved ones, to go to doctor's appointments, to make sure the person's safe. And the caregivers get sick because of the incredible stress. It's so stressful to take care of someone with this disease. Burden and stress results in all kinds of stress-related illnesses. Let's talk about the caregiver. Caregivers can be spouses, significant others, partners. They can be adult children. They can be grandchildren. They can be friends. They can be members of faith communities, neighbors, you name it. There are around 15 million unpaid dementia caregivers in our country. 15 million. And caregivers don't just suffer emotionally, but like I said, they suffer physically. One of the biggest problems is lost dreams. Imagine you go through life, you expect to be able to retire together or have a parent, take care of your own kids, and those things are then lost. But, really important, the person with Alzheimer's disease is not dead. Both the patient and the caregiver, whether it's a spouse or a significant other or adult child, can benefit from maintaining emotional and physical closeness. Second. I want to show you a little clip from Good Morning America.
His wife suffers from Alzheimer's. She doesn't even recognize him anymore, and as you can imagine, the marriage has been rough. My friend has gotten bitter at God for allowing his wife to be in that condition, and now he started seeing another woman. He says that he should be allowed to see other people because his wife, as he knows her, is gone. I'm not quite sure what to tell him. Please help.
Oh, that is a terribly hard thing. It is. I hate Alzheimer's. It is one of the most awful things because here's the loved one. This is the woman or man that you have loved for 20, 30, 40 years, and suddenly that person is gone. They're gone. They are gone. So what he says basically is correct, but I know it sounds cruel, but if he's going to do something, he should divorce her and start all over again. But to her,
But isn't that the vow that we take when we marry someone? That it's
yeah,
for better,
well,
for worse, for richer,
I know
for poor?
if you respect that vow, but you say till death do us part. This is the kind of death.
It is inhumane to think that the individual with Alzheimer's is dead. Let me tell you a little story about this amazing couple, Rita and Saul. Rita and Saul Rogers, they lived in Newton, had a wonderful family. She then developed Alzheimer's disease, progressed. She was in a nursing home. She was one of these awful patients. The type of patient that wouldn't get out of bed, was argumentative, was then not talking, was just kind of grumpy all the time, really difficult with the nursing staff. But wonderful Saul came every day, sat next to her and held her hand. Every day. She wouldn't speak, she wouldn't get out of bed. One day, he decided to do something bold, and that was to ask the nursing staff if he could lie in bed with his wife. His words was to make love to her, which meant to stroke her, to tell her that he loved her. Well, guess what? The nursing staff had to actually have a meeting to see if it was okay. Well, they finally changed their rules and allowed him to lie next to his wife and stroke her and say how much he loved her. Here they are. And guess what? Very soon after that, she started getting out of bed. She started talking. She wasn't grumpy anymore. Now, was that because her disease changed? That her brain was somehow changed? No, absolutely not. It's because the parts of the brain that were still working okay were able to get something, to be touched, to have the love, something that we can't really describe how it works in the brain. But we know that parts of the brain that are responsible for emotions are not hurt early in the disease course. Later in the disease, they can, really late, they can be hurt. Now, he had another idea. She used to love old standards, Dean Martin especially. So he brought in a record player, remember record players, and some old Dean Martin albums. You know, when the moon hits you, I like a bigger pizza pie. Well, she started singing. This woman who not too long before was grumpy, agitated, not speaking, and not getting out of bed. She's then walking through the halls of the nursing facility singing. The brain might be destroyed. The heart is still around. All right, enough of the gushy stuff. Now we're going to science. What is this thing? What is going on in the brain? Well, Alzheimer's disease is, as I've said, a neurodegenerative disease, meaning it starts early and then starts to destroy, to degenerate brain tissue. And it's marked by these two things in the brain tissue that we refer to as plaques and tangles. So, over 100 years ago, we first learned about plaques and tangles when Dr. Alzheimer had his first patient. She was a youngish woman who had severe memory impairment, personality change. It was very striking. She was in the hospital. Dr. Alzheimer was her doctor. People were thinking that she had paranoia. She would talk about her husband cheating with a next-door neighbor. She then died at an early age from the disease. Turned out her husband then married the next-door neighbor. So much for paranoia. But Dr. Alzheimer wasn't just the clinician, he was also the pathologist, and removed the brain and looked at slices of brain with this special stains on it that would pick up some abnormalities. And what he found through the microscope were these things that he described as plaques and tangles. Well, now we refer to those plaques as senile plaques, neuritic plaques, but mostly amyloid plaques, because they're made up of a protein called beta amyloid. So we know that these plaques are made up of, it's kind of a sticky protein that clumps together in this disease, and it's found around the neurons, around the brain cells, and it starts to get in the way of the brain cells functioning normally. It starts this whole process of a toxic kind of cascade. The tangles that he described, now we know, we refer to them as neurofibrillary tangles, and they're made up of another protein called tau, an abnormal form of this protein that we all have in our brain cells, that eventually starts destroying and killing off the brain cells. The abnormal tau kind of clumps together to create these tangles, and eventually the brain cells kind of just break open. And that abnormal tau seems to then move from one cell to another and continues the process. Here's a little cartoon just showing what it might look like under a microscope, where the purple things are the healthy neurons on the left, and the tissue around it doesn't have any problems in it. But on the right, you can see the Alzheimer's brain with the abnormal tangles inside the neurons and the plaques of the protein amyloid around the brain cells. So when I talk about plaques, I'm not talking about the kind of plaques we have in our blood vessels from cholesterol, in heart disease and strokes, things like that. This is just, they're called plaques because they're just these funny looking shapes. And eventually the brain starts getting destroyed and because of this toxic process. And on the left, what you see is, if you cut the person's brain like this, on the left is a healthy brain of an older person, and on the right is the brain that is atrophied with lots of tissue loss in Alzheimer's disease. So it doesn't just come out of the blue, as I've been saying. It's not like one day you wake up and you have it. It's likely that these plaques and tangles begin to accumulate years, if not decades, before any cognitive impairment, before any symptoms. A recent study found that the amyloid seems to start accumulating around 20 to 25 years before the very first symptoms. And so now we refer to as the stages of Alzheimer's disease with this in mind. So first, there's a preclinical stage where there's no symptoms, but the brain changes have begun. And that can last years and years and years. But then once certain parts of the brain start getting destroyed, then the functions of those parts of the brain don't work as well. And so we then have what is referred to as mild cognitive impairment. I don't like the term at all, but that's what's used. Referred to as MCI. And it's used to describe the very first symptoms of Alzheimer's disease before the dementia. So there may be memory and other cognitive difficulties that the person complains about or the significant other complains about. If they were tested formally with memory and other tests, they would be abnormal, but there's no dementia. In other words, it's not bad enough to get in the way of daily life. But then the disease continues to progress and there is a problem with normal functioning. And that's what we refer to as dementia. So it's this continuum. You have the disease for a long, long time, and then the first evidence clinically of it, first symptoms would be mild cognitive impairment, and then it gets worse and worse and gets an impact on your functioning, daily life, the inability to do things on your own, and that's when we have dementia from Alzheimer's disease. So how do we diagnose it? Well, I showed this picture of a typical blood test, finger prick. I showed it to remind me that I used to believe that there would never ever be a test like this for Alzheimer's disease. In fact, I used that same picture just a few years ago to say Now, sorry, there's never going to be a blood test for Alzheimer's disease. But now I changed my mind. I'm actually doing some research now on some folks who have developed ways of picking up those abnormal proteins, the amyloid and the tau, in blood from the brain, measuring the amount of that tau in these little kind of vesicles, these little balloons that can get out of the brain cells, out of the brain and into the blood. And then you can kind of break open these things and measure the amount of tau. This is all very experimental at this point, but boy, are we excited. But for now, it's a clinical diagnosis. That means that without looking at the actual brain tissue, the diagnosis of Alzheimer's disease can't be completely certain. And so the current best diagnosis is based on history, on a clinical examination, on imaging, meaning take pictures of the brain to mostly rule out other problems like strokes or tumors, and a formal memory and cognitive assessment. But the biggest thing is just this. It's just talking with your doctor. But not just the patient. Why? Because the patient has memory problems and maybe lack of insight and awareness, and so the patient's the very last person you want to talk to about having memory problems and awareness. That becomes problematic because maybe the person with the difficulties likes privacy. Maybe they don't have someone close to them. But somehow, there needs to be that communication. Just last week I was giving an educational talk for a group practice of primary care physicians, the Denham Medical Associates, about this. Almost the exact same talk, but more going into how they should diagnose things and treat the disease. But I stressed so much that the most important thing, spending those few minutes to find out what's going on. And what doctors should not say based on their kind of diagnostic process are one of these three way all too common scenarios. Don't worry, it's just a little bit of dementia, which everyone's going to think of as, oh, thank goodness it's not Alzheimer's disease. Remember, it don't work like that. Almost all cases of dementia are caused by Alzheimer's disease. Or how about this one? I'm sorry, I think it's Alzheimer's disease. Have them take this Aricept. Call me in a few weeks and we'll see if we should increase the dose, and you should probably get his affairs in order. What about hope? What about help? What about humor? Or how about this response? I think it's just normal aging. Usually said by an older physician. Well, yes, indeed, it's not easy to diagnose Alzheimer's disease in the primary care office. It's getting easier. Last week I was in California with a group of Alzheimer's experts putting together the recommendations for all primary care physicians around the country of how to diagnose the disease in their office. It's going to get easier for them. But for now, sometimes this is what happens. If you can't see it, it's a rather stereotyped doctor with a nurse coming in saying, if you're stumped, why not write an illegible prescription and hope the pharmacist comes up with something? So that clinical diagnosis, that clinical examination isn't 100% certain. In people who specialize in it, it's not hard to do. For people like myself and others in my group at the Alzheimer's Disease Center, this is what we do every day. It takes around 10 minutes for me to know if someone has Alzheimer's disease, most cases. But that's because that's what I do. In other hands, outside of a specialist's office, it can be complex, difficult. And so, where we are now, in 2015, is the use of biomarkers These are objective biological tests in addition to the clinical evaluation. We can't get rid of that clinical evaluation. But the ability to have a test to help us diagnose it more accurately, wouldn't that be great? I want you to think of this. The brain is the only organ in the human body that does not have the ability to be tested. Every other organ in our body, when it's diseased or has ailments, there's a test for it. Whether it is a EKG for a heart attack, or blood tests for cancer, or a biopsy for cancer, or an X-ray for arthritis, or a broken leg, or liver function test. All those things have a test that diagnose it and let you know how it's doing. The brain, however, is created in a way that separates it from the rest of the body to keep it safe. But by doing so, it also makes it very hard to figure out what's going on in it. Unfortunately, some much brighter neuroscientists around the world have been doing some great work over the last few years and have come up with things like this. This is a PET scan, pictures of a PET scan of the brain, where the person has been injected with a special chemical compound that it attaches to that bad form of amyloid. And it's temporarily radioactive, this compound, only for an hour. And you're not glowing green or anything. And you put the person in a PET scan to pick up the radioactivity. And so what you see on the right, all those orange and yellow kind of hot spots, that's abnormal amyloid inside the brain of a living human being with Alzheimer's disease. On the left, it's not picking up any. That's the healthy, non-Alzheimer's older person. We have things like this now that are actually FDA approved. The problem is Medicare isn't covering it yet. I've gone down to Washington to the Center for Medicare and Medicaid Services to argue with them that it should be covered, but not yet. There's a whole bunch of these new types of biomarkers, including the next step, which is unbelievable to me, the ability to image tau, which people didn't think was going to happen for a long time. And now what we have are pictures like this, also of PET scans with another type of compound that attaches to the abnormal type of tau. And so we can now see the amyloid in that other type of scan and tau in this scan. So we're able to see those things that used to only be seen under a microscope after someone dies. Well, what does this translate into? Using these types of biomarkers, it's now possible to detect Alzheimer's disease prior to having any symptoms. Remember, the disease is on this continuum. So we can actually detect it here instead of dementia phase. Now, a lot of you are probably saying to yourself, why should I know if there's nothing that can be done? Well, we have this kind of catch-22 in research, that in order to move our research forward and to be able to intervene successfully with new compounds, we have to start those treatments before the damage gets too far. Because unlike other parts of the body, once the brain tissue is destroyed and gone, you can't bring it back. And this is a progressive disease. And so if you wait until the person has dementia to intervene, it may be too late. So if we're going to study new drugs and new other treatments to really try to slow down the disease or prevent the symptoms, we have to be able to do it before the symptoms begin. So let's talk about treatment for a little bit. If you can see the picture, the yellow arrow going down is the typical course of Alzheimer's disease, where it starts in preclinical phase, gets a little worse, goes through this kind of fuzzy line, and the person might be diagnosed as mild cognitive impairment. Goes through another fuzzy line as it gets worse, where the person is no longer functioning independently, and we call that dementia. And then unfortunately it continues to get worse and worse, and the person may die. So typically, we would initiate treatment after their symptoms. That's where we are. And it would be great if we could have a cure, some magic pill, when someone already has dementia, that we give it to them and wow, it brings back brain tissue and stops the disease, and unfortunately, I don't think that's going to happen. So, how about giving something after the person has dementia that gives them a little bit of boost? Maybe like a 6-month boost in their memory. Well, that's what we currently can do. Through the available drugs that are used for Alzheimer's disease, such as Aricept, Razodine, Exelon, Namenda, these are all currently used FDA treatments. That's what they do. They get a little boost. The problem is, they just get a little boost. And they only work for some people, and they only work for a short period of time. Because they're not changing the disease. What they're doing is altering some chemicals temporarily while there's enough brain cells still functioning. So that's what we currently have, but it doesn't do anything to change the course of the disease. So now we have these new drugs that are in development that are aimed to slow down the progression. So instead of going down like this, the person has many longer years of better quality of life, better functioning. The problem is that when those types of compounds have been studied in people with dementia, so far they have failed. But one of the things that we believe is that the reason why they failed is because they were started too late. And if you look at the data in the previous studies, the people who were at the earliest phases actually did okay. They responded, and their brain scan showed improvement, less amyloid. And so where we are now is trying to use these same new types of drugs at earlier phases to start them in people who have mild cognitive impairment instead of dementia, to start them in people who don't even have symptoms, but who might have a positive PET scan showing the amyloid is there and that they may develop the symptoms later on. So in other words, what we're doing is we're taking this new approach of slowing the progression, but moving it up so it turns into prevention. Boy, wouldn't that be great? Because if we could delay the onset of dementia by just 5 years, we could reduce the number of people with dementia by 50%. We could cut in half the number of people with dementia. Why is that? They die of something else. But they're not going through, and their families aren't going through the difficulties of having dementia. And so prevention and delay is critical. So let's spend a few minutes talking about other ways that might be helpful for all of us to prevent the progression of Alzheimer's disease. There's nothing out there that will prevent it totally. It's there in people who are going to get it. But there are things that it seems may help slow down the progression. But I'm going to warn you, it's may. None of these things are fully proven yet. One of the things is that what's good for the heart is good for the brain. In other words, decrease heart risk, get rid of all the bad cholesterol, make sure diabetes is in check. Get rid of those things. We've actually found that type 2 diabetes, and even kind of pre-diabetes, something called insulin resistance, is highly associated with Alzheimer's. So we want to make sure that those things are taken care of. And what about diet? There's actually evidence that shows that blueberries and other dark berry fruit might have a really great effect on the brain and prevent these types of destructions from occurring. Blueberries. There's also data to suggest that the omega-3 fatty acids found in fish like salmon might also have a really great impact on slowing down the problem. Olives and olive oil also seem to have a preventive type of impact. Well, broccoli, I've never heard of any research about broccoli, but how could it be bad for you? The most studied dietary prevention has been the Mediterranean diet. And by that I mean eating a diet filled with legumes and nuts, fruits and vegetables, olives and olive oil, especially consuming a fair amount of extra virgin olive oil, eating fish high in those omega-3 fatty acids, and very little red meat. Based on large-scale studies, retrospective epidemiological studies, people who eat primarily that type of diet have a lower risk of developing dementia from Alzheimer's. There's been now a prospective study in Spain where people were put on a Mediterranean diet versus a regular diet, and the people with the Mediterranean diet had less of a progression. And then comes everyone's favorite question, what about this stuff? How many people think consuming alcohol is going to be good for your brain? Here's again. How many people think it's going to be bad? How many people wish it was good? Well, recent research, many recent research studies, suggest that moderate alcohol consumption, meaning 1 to 2 drinks per day for the average weight person, may actually decrease the risk of Alzheimer's dementia. But only if there's no other contraindications, like no liver disease, like diabetes is under control. So checking with your doctor to make sure that consuming some alcohol is okay. The problem is that more than the moderate amount can increase your risk. And once you start having cognitive impairment, continued drinking might worsen the cognition problem. And then comes the question of what to drink. Well, the research suggests that red wine, in particular, might be the most helpful because it contains a chemical called resveratrol. And that resveratrol is one of these wonderful chemicals that seems to decrease inflammation and toxicity. The problem is that in order to get enough resveratrol, you'd have to consume around 2 gallons of red wine a day, which wouldn't be that helpful. So you can actually get resveratrol at the local, GNC kind of store. None of these things are proven, though, but this is the current stuff that is out there. And then weight loss. Yeah, sorry everyone, this is going to continue to be a big issue. Good studies show that being fat in your 40s may raise your risk of developing dementia later, but even people who are overweight later than their 40s, still losing weight can help slow things down. And then the most studied, effective, robust finding is exercise. And that regular exercise can slow down the progression of the disease. Regular kind of aerobic exercise. One study found that the more frail a person was, the more she or he benefited from exercise. And I'm talking about just going for a 20-minute walk. That kind of thing. There's even been an animal study, using these little rodents on these exercise things that found that mice that were bred to develop Alzheimer's disease and develop the plaques from amyloid The ones who were on the exercise thing were much better than the ones who were the couch potatoes watching Oprah every day, or whatever they did, whether they weren't exercising. They actually didn't develop the amyloid. And then one of the questions everyone asks is, what about intellectual stimulation? I've heard that's good for your brain. Yeah, there's all kinds of things. Playing cards, being part of a book group, doing your daily crossword puzzle or Sudoku, or working on the computer, whatever it seems to be. Well, what is it that works best? It's not just one thing and keeping up with that crossword puzzle, let's say. What it is trying new things in new ways, taking up a new language, taking a new route to work or to the kids, or trying new recipes, reading a different genre of book, starting a new hobby, or rekindling an old one. Then social interactions also seem to help with the prevention of this disease or the progression of the disease. So some studies have shown that maintaining strong social connections or developing new ones might help prevent the dementia. All right, so with all that, what's needed? Where do we need to go? Well, because of us baby boomers, yes, we have a growing number of seniors, and with these new drugs being developed, we're going to have the ability to modify the disease course, and all that translates into more and more individuals living with this disease and at earlier stages of severity. So, quality of life has to be, in my mind, the most important thing to focus on. Not just for the patient, but also for the caregiver. So what does that all translate into? Well, we need more support, more facilities. You're very fortunate to be here at Quincy with the Kennedy Center, with all the stuff that is offered here. We need caregiver support. We need caregiver respite. There's a wonderful thing that is now available up in southern New Hampshire. It's a gorgeous 200-year-old farm, bed and breakfast. Just the most beautiful farm setting. It's called the Stonewall Farm Bed and Breakfast. And it's run by a woman whose husband died of Alzheimer's disease at a young age. And what she decided to do was to make this beautiful bed and breakfast an Alzheimer's caregiver respite retreat. And so the caregiver can have a place to get away to for a weekend, for a night, whatever it is, and be pampered. There's massage, there's Reiki, there's all kinds of things. There's also grief counseling, the ability to talk with people, to share their experiences, or just to have a nice walk around this beautiful farm, and great food. That's what's needed, things like that. Adult daycare programs. We need many more of them, and they need to be specialized for dementia, and they need to be personalized for the stage of the dementia, and the age of the person. And we need more and more assisted living facilities and memory support residences that are specialized in dementia and based on scientifically based programming, such as the COMPASS programs by senior living residences. If you didn't take the information, I think there's information. Isn't there? Is there information?
There will be.
There will be. All right. The COMPASS programs provide unbelievable memory support residences with great staff, but also because they are based on what we know is the best way to help people with this stage of Alzheimer's dementia. Using things like music. I put this up because my own son, Nick Simmons-Stern, was one of the people who did some of the early research on the ability of music to help people's memory with Alzheimer's. Using arts in general is fabulous. If you haven't seen this documentary called I Remember Better When I Paint, do so. If the Quincy Senior Center doesn't have it, get one to be able to share with your residents. I happen to be in it, so I'm biased, but it's a great documentary to show how important the arts are. And then what I want to leave you with is the importance of research participation. This isn't just from a selfish point of view as an Alzheimer's researcher. It's from the point of view of someone who really wants to get rid of this thing. I want to make a difference. I want to get rid of the symptoms. I want to do something to decrease the pain and suffering and difficulty that people have with this disease. I know that it's a lonely disease. I know that it's a disease that can be without hope. And so one of the things that can be done is to participate in research to, number one, play an active role in one's own health care. To also gain access to potential treatments before they're available to the rest of the community. To be able to receive expert care at leading healthcare facilities, almost always free of cost. Perhaps very importantly, most importantly, is to make a connection. By participating in research, by going to a place where they truly understand what's going on, the person is not alone, the caregiver is not alone, because there are people who get it. I happen to be the luckiest man alive, in addition to having the most wonderful family. I also have an incredible staff. And that staff truly gets it. And I'm not alone. All the other kind of Alzheimer's centers around also are fortunate to have great staff. So when you go to participate in research, there are people who understand. And by participating, it does maintain hope. Not just hope for one's own future, but also for the future generations. So there is a research study for everyone. If you look at that newsletter, the glossy big thing that you have with the red stripe on the top, in the middle of it, you'll see a listing of a whole bunch of studies that are available. I think another handout that you have is a list of currently recruiting studies. There's a study for everyone. But typical questions that people have are, number one, do I have to come to Boston? Even you Quincy people complain about coming to Boston. Well, yes, for most studies you do have to come to Boston. We do have some studies where people can be seen other places, but for the most part, they have to come to Boston. However, if transportation is difficult, we will get you there. We will get you there, either by paying for your gas and parking, or we'll send a car or a cab. Transportation should never be the issue. Do participants get paid? In some studies, yes, participants and caregivers can get paid, but not all studies. Is there any oversight or protection for the participants? People are afraid that they're going to be treated like guinea pigs. Well, we're not in the days of Tuskegee anymore. Those of you who remember that awful experiment. There are so many levels of oversight by different committees all along the way, nationally, locally, to make sure that a study cannot be done unless it is appropriate and safe for the participant. Now, people want to know residents in assisted living or in nursing homes can participate. Usually not nursing home residents, but yes, people who live in assisted living programs can participate in many of our studies. But almost every study does require a study partner, someone who knows the patient well. Do all studies involve medications? No. We have exercise programs, some nutrition programs. We do have studies for caregivers to help reduce stress. And then can I quit? Yeah. You always, as a participant, can stop participating. And is it confidential? Yeah. If it weren't, we could not continue. So, what I want to leave you with is a concept that I refer to as just one. You'll know what this means in a minute. It is indeed shocking that even here in Boston, the Mecca of medicine, it is difficult to recruit people to participate in Alzheimer's studies. This is a national problem. I can't tell you the millions and millions of dollars that are spent annually to help recruit people into Alzheimer's research. I want you to think about cancer. If someone is diagnosed with cancer, it is almost expected that they would be offered to participate in clinical trials, and they would jump to the ability to be at the forefront of it. That doesn't happen in this other disease that is also a fatal disease, Alzheimer's. Primary care physicians don't know that there's research. People think that everyone else is participating. But if this talk could result in just one person to become enrolled in our research, it would make the big difference, just one. So, spread the word. I'm not looking at all of you to participate necessarily, just spread the word. If we can just get one person involved, that would be tremendous. You have materials that have the phone number and the email, but also where is that sign-up sheet? It's right there. Roz, you have that sheet. Now that I've given my pitch about the importance of research, if anyone would like to, there's right behind you, Roz, there's there it is, the clipboard. If anyone didn't fill it out, but would like to, if you could perhaps pass that around, that would be great. If you filled it out but you didn't say you wanted to learn about research, please take it back. That would be fantastic. If you have friends or family members in other parts of the country and you want to find out about availability for them to participate in research, well, there's this thing called Trial Match from the Alzheimer's Association, which is a terrific thing to do. You just go online or call the Alzheimer's Association and find out about Trial Match. Anyways, I want to end with this. This is some of my staff who are the wonderful, smiling, understanding faces who would be working with people who participate in research. But it does all come down to this, to hope. And if you need help with evaluation, diagnosis, starting with the Alzheimer's Association. There's a private practice in Newton that does a sensational evaluation and treatment that works with us closely called the Boston Center for Memory. And then there's our Boston University Alzheimer's Disease Center, and that information's in the stuff you have. And then finally, it all comes down to one final important thing. Don't forget that humor. So with that, I'll end. Thank you very much. Questions? Yes.
I think I missed it, but when you were speaking, it's kind of like I'm 57, and in my primary care physician, I said to her, so I have to have this colonoscopy, which I had no issues with. But what about people getting early testing for Alzheimer's? Now, did you state that Medicare doesn't cover that, or health insurance? Because she looked at me like I was looking totally different. She said, oh, we don't do that. So I said, well, that seems more important to my life than the colonoscopy.
So the question is there a way to have early testing for Alzheimer's disease, like a colonoscopy? So currently, no, except in research. So there are research studies that will do that, one of those PET scans that can be done. If you were really wealthy and you had symptoms, then you could get one of the PET scans done, but you'd have to pay for it, okay? But right now, we don't have the equivalence of a colonoscopy. And that's the big issue. And that's where some of this research is focused. We're doing a whole lot of studies trying to come up with these better, accurate tests to diagnose it before someone has symptoms. So like a colonoscopy, you can find out early and then do something about it.
That would be the PET scan, right?
it's PET scan, it's other things. There's like there's spinal taps, and now we're coming up with blood tests. So it's a whole bunch of things that aren't yet there, but we need to continue the research because those things will be there in the next few years. But only if we get people to participate. So you hit the nail on the head that just like you go for the colonoscopy and you say, but I don't have any symptoms, I don't have any problems, I don't have any family history. Well, no, you've got to have that colonoscopy. Or for men, having the PSA test, or having a mammogram, all these things. Those are those biomarkers that are available for all other diseases. So what we're hoping is that there's going to be the equivalence of a cholesterol check for the brain for Alzheimer's disease. That's going to happen. It's just not there yet. Great question. Yes?
Are you familiar at all with Dr. Chen's work in association with LSU using, I think they said, a COX-2 inhibitor with a THC derivative in alleviating some of the effects, and do you think that's a worthy aspect to start?
Yeah, so the question really gets down to there's some research that uses what's a cannabinoid, and it's a marijuana type of derivative without the high of marijuana. And these cannabinoids seem to have some effect on helping the brain fight the toxicity. However, it's one of those things that has some early findings that haven't necessarily been replicated and needs bigger studies to find out. When you hear something in the news about a new study, a new breakthrough, you're probably all used to hearing about it, and then it goes away, and then you find out a year later or so, oh, it didn't work. Take those things with a grain of salt. This is an incredibly complex disease. There isn't going to be one treatment that does it all. There's probably going to be multiple different types of treatments that are used for different people at different stages of the disease, kind of like the personalized medicine that you hear about these days. Other questions? Beck?
I was intrigued by the self-portrait of the artist. So, what does he see when he looks at himself? Does he actually see him for what he is? And that's why the painting is done as it is? Or is there a disconnect between what he sees and his ability to replicate it? Does that make sense?
It's a wonderful question. For those of you who couldn't hear it, it's going back to that artist, William Mutamala, or any person with Alzheimer's disease.
Yeah.
But in that case, when you see the outcome painting, is that painting a reflection of what he sees or what he can do with what he sees, or just what he does? I don't know. It's impossible to get into the reality of the person with a brain disease like Alzheimer's disease. I'm guessing that it's a combination of the two things. What he actually sees, but how he then can get it out. The getting it out is the most difficult because it requires all kinds of brain systems to work together. So probably the majority of the difficulties are getting it out. The person with Alzheimer's disease does not see the world in a distorted way. The vision is okay, but dealing with spatial information and then manipulating it, that's the more difficult part.
My family has a history of Alzheimer's. My mother had it, my grandfather had it. And I actually called Medicare because I wanted to go in and get a PET scan. And they told me it was covered. They're saying it isn't.
The PET scan is not covered by Medicare, especially for someone who's not symptomatic. Someone with symptoms who has a very difficult differential type of diagnosis, in some ways, if it's related to a research study, Medicare might pay for it. But for the routine person who has a family history and is concerned, there's nothing really that can be helpful for you. So when there are some issues, then the best thing to do is to see a doctor or get involved with a research study, or both, hopefully, and that way you're followed. And that's the good thing about many of these research studies, is that you're followed on a very regular basis. We have one study, it's kind of like the flagship study that I run called the HOPE study, that is just an annual assessment to see how someone's doing. And we have people who are healthy, older, kind of controls, and we have people with mild cognitive impairment, and we have people with dementia. And we follow people with a whole bunch of different tests, including PET scans, including blood tests, and you name it. But also very extensive cognitive assessments and neurologic assessments. So that's the key. People will then ask, if I have a family history, does that increase my risk? You know, mom had it. Am I going to get it? Well, the short answer to that is having a family history of a first-degree relative, meaning a parent or a sibling, does increase your risk of developing it yourself later on. Unless that person started having symptoms at age 85 or older, or if you're 85 or older. At that point, age itself is the biggest risk factor. So, having a family history increases risk, but it doesn't mean you're going to get it. And then comes the question of genetics. Well, the easiest answer to, is there a gene that causes Alzheimer's disease, is no. Except there are rare forms of Alzheimer's disease that occur younger in life, where there's families around the world who have this type of dominantly inherited gene. There's one of 3 that we know of. And if you have that abnormal gene, you will get it. So one of the most studied groups, extended families, is in Colombia, South America, where these incredible people have been really devastated through the decades, because half of all families get the disease, or more. They get the symptoms at a very early age, 20s, 30s, 40s, and then die. But that's not the routine Alzheimer's disease. Run-of-the-mill Alzheimer's disease is like 99% of all cases. And for that, we have no single gene that causes it. We do have some genes that are what are referred to as susceptibility genes. It's kind of like the breast cancer genes, BRCA1, BRCA2. If you have the bad form, it increases your risk of getting breast cancer, but it doesn't mean you will get it. And if you don't have the gene, it doesn't mean you won't get it. Same thing with a gene called ApoE. If you have the bad form of this ApoE gene, it increases your risk of getting Alzheimer's dementia, but it doesn't mean you will get it.
There's a couple of things that have been advertised quite a bit that help. It's supposed to help, like coconut oil, cumin, somebody else mentioned CoQ10.
Yeah. So all these things that you hear about, you mentioned coconut oil, no, hogwash. Okay. Cumin, possibly. That's something that is being studied. It's a common ingredient spice in curry, and it seems to maybe have something good going on. CoQ10, it's not really that well studied or not. But again, most of these things, maybe something there, and we just don't know. One more question? That's it. Well, thank you very, very much.